Hi, everyone. Welcome to today's webinar. I'll go ahead and pass it over to Dr. Gagnon, who will be chairing and moderating today's session.
Hi, this is my great pleasure to welcome you to this NMD4C webinar hosted by Muscular Dystrophy Canada on oculopharyngeal muscular dystrophy. We have a great team of presenters. We will first see our research perspective in Canada. Then I will introduce you to Claudia Cote, which will talk about dysphagia, Dr. Jean-Denis Brisson on strength and mobility, and finally, for dessert, Dr. Bernard Bray on the scientific insight and treatment of Opmd. I'm Cynthia Gagnon. I'm an occupational therapist by background, professor at the University of Sherbrooke, and director of the Groupe de Recherche Interdisciplinaire sur les maladies neuromusculaires, so the GRIM, in Saguenay. We have several learning objectives. And I'll have the pleasure to start this session. And I am an unpaid consultant for Silos Therapeutic, and I receive a research grant from them. So Opmd is an hereditary dominant disease with some rare case of recessive transmission. It is a proximal myopathy, including ptosis, dysphagia, followed by upper and lower proximal weakness. Dr. Bray will talk more in length about the pathophysiology, but it is an abnormal triplet expansion disease. The highest prevalence is in the French-Canadian population in Quebec, Canada, due to a founder effect. But there's also a cluster of patients in the Bukhara Jews of Israel and in an Hispanic population in New Mexico. What I will present to you today is really an ongoing research program that focuses on optimizing trial readiness by following the roadmap to patient-focused outcome measurement in clinical trial as proposed by the Food and Drug Administration. And really, this leads the way to have the data prior to clinical trial, which is understanding the disease or the condition by natural history study, defining patient subpopulation or healthcare environment, conceptualizing treatment benefit, so what the medication or the treatment or the intervention will have as benefit, and then selecting or developing the best outcome measure to assess the potential treatment benefit. We have started in 2015 with a retrospective chart review that was conducted by Dr. Jean-Denis Brisson, which you will hear later, where the idea was to identify the key motor impairment present in Opmd, age of onset of symptom, and explore their progressions. We moved on to a natural history study that we just completed in 2020. We had to stop because of COVID, but we were still able to assess 34 patients. And Jean-Denis and Claudia will present some of the results that we gathered. And this has led to a CIHR grant funding application that was just submitted. And this will move this pilot natural history study to a Canadian natural history study, including Saguenay, Quebec, Montreal, and Ottawa Neuromuscular Clinic, if we're lucky with CIHR. In conjunction, we work over several years to make a great selection and validation of dysphagia outcome measure. And you will hear some of the work that we did with Claudia. And we are moving on also to select the best motor outcome measure in this disease. So let's start with the retrospective chart review and the onset of symptom. We were able to review 333 patient chart with the same genotype from the neuromuscular clinic in Saguenay. At this clinic, the nurse case manager do an annual follow-up with each patient, either by phone or in the clinic, and they use a standardized clinical assessment. So that was the basis for the chart review. And what we see is that the age of onset of ptosis and dysphagia was around 54 years old, followed by lower limb proximal weakness around 50 years of age. And then some 10 years later, we start to see appearing fatigue, dysphonia, and pharyngeal pooling of thickened secretion. But what is important to also highlight is the wide range of age of onset of symptoms, which really highlights the clinical variability of this age of onset, but also that it is difficult to, given the bias that age of onset is not a very solid variable. We also look at the latency between the onset of the first symptoms and subsequent symptoms. And what we see is that for most patients, the first symptom is either ptosis, dysphagia, or both. They approximately arrive around 50 years of age, followed by the onset of the second symptom between 3 and 5 years later. And then 7 to 6 years later, we see the appearance of proximal weakness. We also look at the cause of death in Opmd, and what we see is that 32% of our sample died from disease of the respiratory symptoms, mainly pneumonia and influenza. The median age of death was 77 years old, with a longer life expectancy for women as in the general population. One important point to highlight is that once the proximal weakness is appearing, we see a shorter survival time than at the onset of dysphagia or ptosis. We also highlighted that there was not a lot of other comorbidity, or they were similar to the general populations, which really highlight that there's potentially no extramuscular manifestation in the most common genotype. Following that, we also look at the impact on participations, which is very important. So what is the impact of having Opmd in daily activity and social roles? There's very few studies that have looked at this either in Canada or elsewhere. The work of Dr. Yusuf in New Mexico have highlighted in a qualitative study that there is several impacts, including reducibility to do household chores, premature retirement, difficulty with stare, and community outings. She followed up with a study on health-related quality of life, showing that it's lower than in the general population, and the physical domain being more affected than the mental domain of the SF-36 scale. One point that was very interesting is that dysphagia severity is moderately correlated with the social functioning subscale, which really highlight the impact of dysphagia on the ability to go for family dining, going to the restaurant, etc. There's also another piece of work that was done by our colleague from the clinic in London, Ontario, where they looked also in a qualitative study about the impact of living with Opmd. And they highlighted the need for adjusting to change and managing misconception, particularly in regard to ptosis, which often other people think that they are fatigued or not interested. Also the need to seek for normality related to dysphagia, including their difficulty with nutrition and socialization around mealtime. Also facing the future with the progression of the disease, their fear of choking, and informing children as it is a dominant disorder. We also conducted some study on participation in our natural history study, looking at a patient-reported outcome, the life age, which look at different domain of daily activity and social activity. And what we see is that it's a score of 10, and mobility, nutrition, personal care and health, and recreation show a lower score among the older patients, so over 60 years old. And the mobility and recreation show larger differences and score below 8, which imply that they have a need for help while doing those type of activities. But what you see again is that there is a large variability for each domain. So the score can go from 3 to 10 for mobility, even in the patient that are less than 60 years old, where you would think that they would have a score around 9 or 10. So really showing a variability in the impact of the Opmd. So I would like to thank our founder, and I will take a few questions and then we'll move on to dysphagia with Claudia. So I'll stop sharing and I'll be ready for answer. I'm sorry, my dog is always having something to say while I'm presenting. Hopefully it won't interfere. Amira, is there any question or we can move on?
Looks great. We can move on.
So now I would like to present Mrs. Claudia Cote. She's my doctoral student in health science research at University of Sherbrooke. She's also she received a research bursary from the Fonds de recherche du Québec en santé. And she is a nutritionist by training. She's been working with me for the last several years on dysphagia, and will show some of our preliminary results. Claudia?
Yes, thank you, Cynthia. Hi, everyone. It's a pleasure to be with you. First of all, I would like to thank BioBlast and Silos Therapeutics for their financial support of our work. Okay, so today we'll see the particularities of dysphagia in Opmd, and we'll learn about the importance to question the patients, not only about characteristics of their current swallowing disorder, but also about any changes in diet or modifications in eating. Dysphagia in Opmd rarely starts before 40 or after 70 years of age, with a median age of onset of 54 years. It is slowly progressive, so patients are likely to discover compensations over time that keep their swallowing problem at a manageable level, sometimes for years. This is especially true for patients who may benefit from the experience from older family members. Both pharyngeal and oral phases of the swallow process may be affected, but pharyngeal symptoms are more prevalent and burdensome than oral symptoms. Finally, difficulty swallowing is typically first noticed for solid foods and then progressively for liquids. Our team did a systematic review of the symptoms, and here's a list of the key symptoms according to an expert panel composed of researchers and clinicians who have been working with Opmd patients for more than 5 years. And you can see that the key symptoms are divided in two categories. So you have swallowing impairments with swallowing difficulties, food getting stuck in the throat, and coughing and choking on food. And we have coping strategies with decreasing bite size and sips, longer meal duration, and food selection modification or avoidance. It is important to know that swallowing difficulties is a very general symptom, but may be more specifically addressed when associated with food texture. For example, patients may have more difficulty with hard and dry foods, such as steak, bread, raw vegetables, and so on. Now, why is it important to specifically address the symptoms and ask about coping strategies? First of all, patients may fail to report some important clinical symptoms when asked general questions. Coping strategies can be so effective that patients perceive little change in their symptoms over long periods of time, and patients may have a significant nutrition risk due to diet choices, according to a study conducted by our research team. So if you don't ask the right questions, you can miss important information. Let's see an example. So we asked 255 OPMD patients aged between 50 and 70 years old with a mean dysphagia duration of about 10 years the following questions. Since the beginning of your symptoms, does food get stuck more frequently than before? And does food get stuck more severely in your throat? As you see, the answers vary according to the way we ask the question for the same symptom. Now let's see what happened when we ask a different question. We asked to the participants, since the beginning of your symptoms, are you more careful when you eat? Here you can see that 88% of the participants chose the answer yes a lot. And here's a quote from one of them. I have learned which foods I need to be more careful with and can avoid difficulty while eating. So swallowing impairments are closely related to the concept of being careful when eating, which refers to coping strategies and food texture. Here's a list of coping strategies that OPMD participants may use, and you see that the different strategies are not equally applied to all the food they eat. For example, eating slowly may be used for a majority of food, but drinking is more used with some kind of foods, I would say dry foods. If despite these strategies, a food starts to cause problems again, patients may tend to avoid it, which brings us to our last question. We asked to the participants, since the beginning of your symptoms, are there any foods that you don't eat anymore? And for this question, we divided the participants according to dysphagia duration. The graphic shows a significant association between food avoidance and dysphagia duration. So we can hypothesize that food avoidance is more present when dysphagia becomes more severe. And here's another quote from one participant. I've adapted and modified my diet, so if anything, I have less trouble now than in the past. I let you think to what would be the answer of these participants to the question, do you have difficulty swallowing? So as I said earlier, patients adapt their diet and therefore they may have a significant nutritional risk due to diet choices. And here you see the results of our assessment of nutrition risk among a group of OPMD patients compared to a group of participants without swallowing disorders. Participants with high nutritional risk are almost twice as high in the group with OPMD than in the group without swallowing disorders. In addition, OPMD participants have a lower body mass index, still normal, but according to recent study, body composition may be altered in people with primary neuromuscular disease, with proportional reduced muscle mass and higher fat compared to healthy people, despite normal BMI. Further studies are needed to confirm this in OPMD patients, but there is clearly a need for nutritional risk screening and dietary counseling in OPMD patients, in addition to dysphagia assessment. Now we come to the question, what is the best way to assess dysphagia in clinic? Work in progress. In terms of performance measures, we have the 80 milliliters drinking test, a simple screening test for the detection of dysphagia in OPMD. It consists of the subject drinking 80 milliliters of cold water as quickly as possible without choking, and failure to drink 80 milliliters of water in less than 8 seconds suggests the presence of dysphagia. This test has shown to be easy to perform with an SOP developed by our research team, reliable among patients with less than 20 seconds drinking times, and potential entry criteria for therapeutic trials. Now, in terms of patient-reported outcomes measures, there is no PRO specifically designed for OPMD. Our recent review of literature has shown that 5 questionnaires include items related to the 3 key impairments. However, they do not account for coping strategies. Nevertheless, we pre-tested 3 of these questionnaires in the context of a pilot study. We wanted to test if they were able to differentiate between dysphagia severity as measured by the drinking test time. So we pre-tested the Sydney Swallow questionnaire, the SSQ, the E10, and the SWALCO. And as you can see, the SSQ and the E10 can differentiate patients by dysphagia severity as measured by the drinking test time. And it is interesting to notice that patients with less than 8 seconds are presenting with symptoms. The SWALCO was not able to differentiate dysphagia severity, maybe because it assesses symptoms with a frequency scale. And please note that these questionnaires don't take into account coping strategies. We are currently working on the OPMD specific PRO, and we hope it will be soon available. So thank you for your attention, and thanks to all our supporters and our research participants.
Thank you, Claudia. Is there any question for Claudia? I think we're good. Oh, there's one. Oh, there's a question from Dr. Lockmiller. Can you tell us what is the eye nutritional risk?
Yes, thank you. It's a good question. In our study, we assessed nutritional risk with the screen 2, which is a patient-reported outcome questionnaire. And it has a question about foods, eating habits, and sorry, English is a little difficult for me. I don't know if you want more about more information about the screen 2.
Well, I can partly answer on that if you want. So it looks at protein. Well, Claudia, this is our first presentation, so so it's about protein intakes, and tell me if I'm getting it wrong, but so it's the different intakes of essential nutriment partly. So to make sure that they have enough protein and glucid and fat intakes. So it's a self-reported, it's more of a screening tool, but it's well validated in the Canadian population. It's often used in those large cohort study, but it needs to be validated with a Journal of Dietary Intake, which is a more formal and a more quantitative assessment. So that's what we'll be doing if we get funding.
Thank you.
Okay, I think we're good. So can you unshare your screen, Claudia? And I'll introduce to our third presenter, which is Dr. Jean-Denis Brisson, which has done his training in neurology at Enfant Jésus Hospital in Quebec City. He is the neurologist and the newly appointed medical director of the neuromuscular clinic in Saguenay-Lac-Saint-Jean. He is an associate professor at Sherbrooke University, and he's completing his master in clinical research on OPMD. So I'll let you, okay, good.
Okay, so thank you very much for the introduction and also for the opportunity to present tonight. So I will talk about an important topic, which is on strength and mobility and OPMD. I have no disclosure for this presentation. The objectives are to describe the progression of muscle weakness and motor activities in OPMD, and also to establish the impact of muscle weakness in subjects affected by OPMD. In that talk, I will focus on skeletal muscles in upper and lower extremities. I will not talk about pharyngeal muscles or eyelid. I will first talk about the prevalence of weakness in lower extremities. So it's based on the retrospective study that Professor Gagnon mentioned earlier. We looked at charts from 333 patients followed at the neuromuscular clinic in Saguenay. And we found that the age at symptom of onset for the proximal weakness in lower extremities it's mostly between the age of 50 to 70. So we can say that between the age of 45 to 69, about 90% of participants reported that their weakness started in that period of time. And it's more rare to have the weakness appearing before the age of 45 or after the age of 69. So you can see that distribution on the right. We mentioned earlier that we looked at the age of onset of key symptoms frequently reported in OPMD. From the retrospective study, we saw that the lower limb proximal weakness is reported with a median age of 58 and a large range, as I mentioned. So it was between 41 to 77. After that, some patients are wondering after the occurrence of a first symptom like ptosis or dysphagia, when will appear or manifest the proximal weakness in lower extremities. So we could see from the retrospective data that it's about 6 to 7 years later. It's rare to have proximal weakness in the lower extremities to be the first symptom reported, and almost all experts would agree to say that when we measure weakness in the lower extremities, usually there's a mild degree of ptosis or dysphagia. OPMD has many impact on the life of patients. From a study from New Mexico, they report that 23.6% of participants were having working incapacities related to OPMD, and also that about 20% of participants were retired early because of their disease. Again, from the study, the retrospective study we did in Saguenay, as mentioned, the nurses are annually reaching the patients by phone, and we looked at the incapacities like difficulties to stand from a crouch position or sitting position, climbing stairs, having charges over the shoulders. And we saw that before the age of 70, a large proportion of participants were having incapacities to walk over 150 meters. So it reached 16.8%. Also, 7.6% of participants could not climb stairs independently, and 21.3% were using a walking aid, from which 8.4% were using a wheelchair. All that before the age of 70. I will now talk about the affected muscles in OPMD. From MRI studies, we can see that there's a fatty replacement in tongue, adductors muscles, soleus, and also in hamstring. A large study in New Mexico with 144 subjects evaluated manual testing on 15 muscle groups. So they did that with a MRC scale, which is usually used in the clinic practice. And there was a high prevalence of hip muscle weakness reported. And they also found that the presence of a more severe hip muscle weakness would predict the need for a walking aid at a younger age. Now I will talk about the prospective study. We just finished the data collection and the analysis. So it's a study we did in Saguenay, over 34 patients with Opmd, with a range of age between 42 to 73. We evaluated 9 muscle groups with dynamometers or pinch meter. And we also did 6 functional tests and questionnaires. We found that there is a declining strength with age for shoulder flexors, for pinch, hip flexors and extensors, and also for hamstring. We then compared the performances at the functional tests with normative values for healthy subjects of the same age. And we found that for the test I will mention, that the performance was under 80% of what was expected. So these tests were the 30 seconds chair stand test. So participants have 30 seconds to stand from a chair and then go back to the chair and do as much repetition as they can do, as much as possible. And then we evaluated the 10 stairs climbing and also descend. The hand prehension test and pinch test were all affected. After that, we saw that the walking endurance is affected. We used the 6-minute walking test, which is a test largely used in muscular dystrophies and other neuromuscular diseases. And we compared with existing normative values again for healthy subjects of the same age. And we saw a performance at 67.3%. Also, another study compared the 6-minute walking test with healthy subjects and found that there's a reduced walking distance over the period of 6 minutes. Now I will briefly talk about the interventions that we can propose to patients. There are a few studies on exercise and muscular dystrophies, but there is no published data in Opmd. There's a theoretical risk of muscle damage in more severe myopathies like hereditary muscular dystrophies or inflammatory myopathies. But there's no harm demonstrated on muscle in Opmd, and as it's a milder muscular dystrophy, there's no reason to think that there would have a significant damage. So we encourage the patients to be as active as possible to overcome the fatty replacement and atrophy in the muscles. Usually at the neuromuscular clinic, when patients mention that they have weakness in the lower extremities, we make them meet a physical therapist to do a reinforcement program for lower limb extremities. So there's a baseline strength evaluation, and then we ask patients to document their physical well-being while doing their exercises and after the exercise. We don't want them to experience pain, or we don't want to exacerbate the fatigue. In conclusion, so the weakness in Opmd affects mainly proximal lower extremities, like hip as mentioned, and also eventually the proximal upper extremities and distal to a milder degree. There's a significant impact of the disease as patients will use a walking aid earlier. There are working limitations. And also we saw that there are functional limitations like difficulties to stand from a crouch to standing position or sitting to a stand position. Also using the stairs and even walking. We encourage exercise a lot and reinforcement program if necessary. And it's exercises that they can do at home, I didn't mention. And it should focus on hip muscles function and also hamstring. So it's important that future therapeutic trials should have motor capacities evaluation as a main outcome in the future. So I thank you very much for your attention and presence, and here are my references. I will now take questions.
Thank you. Is there any questions?
There's one.
Yes, okay. What is the percentage of losing ambulation after age 70?
For losing ambulation, yes, it was measured with the incapacity to walk over a certain distance. Or people usually when people use a wheelchair, it's to do some distance, but usually not full time. It happens that the patients need a wheelchair fully after a certain age. To see the percentage of patients which are not ambulant, I would have to look at this exact.
I can help. I check. It's 14% over.
Oh, okay, thank you.
I've checked in the so in the retrospective study it was 14% after 70 years of age, which is a lot higher than in the Canadian population, which I think is around 5% or less. So I cheated. I looked in the study.
Thank you.
I think there's another question about, whoops, I'm just trying to get back to the chat.
Yes,
oh, yes,
they're asking if, is it true that people with Opmd should avoid eccentric muscle contraction? I didn't see anything about that. And as I mentioned, there aren't any specific study in Opmd. I saw there's one ongoing now, but there's no result published. So I didn't see in the literature that mentioned. I don't know if Dr. Bray or I would think it's not exact.
I think the answer, I mean, we did some study in myotonic dystrophy, which is totally, of course, different disease, but we took muscle biopsy before and after eccentric exercise, and we showed that there was no damage to the muscle. And eccentric exercise is the way to increase muscle mass. So it can be, we still need to validate if it's totally safe, but we're moving more and more to exercise programs that are more demanding on patient, but we have to make sure that it's safe. So we got another question. I can only do swimming pool exercise. Do you have other recommendation?
I don't understand. So there's only only the possibility to do a swimming pool training. Usually, or maybe the exercise programs made by the physical therapists at our clinic are pretty simple. They involve usually like squats or reinforcement of hip extensors. So I think a lot of physical therapists would be able to do a program knowing that hamstring and hip function are important to reinforce.
Oh, so I didn't know that one with OPMD could increase muscle mass till exercise are thought when so weak. Well, I can take that. Earlier in the disease, people still get muscle mass. So it always depends on where you are at the disease. So I think it's a good intervention. When you're getting weaker and weaker, then it's difficult to get muscle mass. And then it's dangerous. I mean, the recommendation is really to consult with your neurologist and then to see with your physical therapist what can be done in a safe way, given the progression of your disease and where you're at in terms of muscle mass. So I think that's the recommendation we usually give. So it's difficult to give personal recommendation because it depends on how far you are in terms of muscle loss, I think. There's another one. Any cardiorespiratory concern? Do you prescribe aerobic exercise for fatigue?
Cardio, no concern for cardio problem. Respiratory, we're investigating that. We hear a lot that people experience more dyspnea, but we're investigating that. We think there's probably something, but we don't know yet. Aerobic exercise for fatigue. Usually we recommend exercises even when there's fatigue, but we don't want that to exacerbate that fatigue. Also, we suggest energy conservation strategies like not being at full maximum performance every time of the day. People should keep moments where they are more calm and recover. So these are some strategies that we also suggest to compensate for the fatigue. Yeah, it's a frequent symptom reported.
Okay, I think we're good. So we can move on to, thank you, Jean-Denis. And we can now move on to Dr. Bernard Bray, which is a full professor of neurology and neurosurgery and human genetic at McGill University in Montreal. He is a trained neuromuscular neurologist, PhD in laboratory human genetics and historians of medicine. He is the co-director of the Montreal Neurological Institute's Rare Neurological Disease Group and of McGill Neuromuscular and Neurogenetic Fellowships. It's my pleasure to introduce Dr. Bernard Bray. All yours.
Thank you for the invitation, and thanks for the team presenting a good summary of their work. So I have a few disclaimers because unfortunately or fortunately, I've been in the field for many decades now. So I did partake in the first Trehalose trial, hoping that there will be another. And I've been an advisor to different medical boards to companies interested in developing treatment for OPMD. So I will talk a bit about the pathophysiology and then talk a little bit about a review of treatment options. Well, I will not specifically talk about physical therapy as it's been discussed before, but I may make a few comments on that. So we're over 20 years now since the discovery of the gene. I wanted to insist on the fact that in fact it is a Saguenay family. That was the one that led to the discovery of the gene, a family where family members had been seen by Jean-Pierre Bouchard and Jean Mathieu, my two clinical mentors. on Opmd and many other of the French-Canadian conditions. And this, can you just imagine the size of this family? We had 168 people, the family, partaking in the study. So amazing solidarity. And so it makes sense to me that we probably have over 1,000 patients affected at this point in Quebec living, that a quarter of them are in Saguenay-Lac-Saint-Jean. So it's probably not the region per capita where it's necessarily the most common, but it's reasonably common. And because all cases are followed in one clinic, it makes so much sense that they are also the people promoting better outcome measures and setting the stage for clinical trials in Quebec. And for the other people across Canada who have this disease, and most of them are of French-Canadian descent, but we have people of many other ethnic backgrounds with this disease. But the slide is also to introduce the idea, and I know for some of them it's a difficult idea. It's the idea that what's the cause of the disease? It's a mutation that lengthens a stretch in a protein. Proteins are like beads, and instead of having 10 beads of a certain color, you will have between 11 and 18 beads. And from 12 on, it clearly causes a disease that will go from generation to generation. It's what we call a dominant disease. It's a disease that has appeared in history. The mutation has appeared in history many, many different times. 98% of French Canadians share the same historical mutation, but probably not all. So we need to understand that to think of therapy. So what happens when those beads become bigger? It has an impact on the protein. And that was what you see in the center is a nuclei of muscle. And that's what you see in the center of it, is all this accumulation of protein. So in fact, it is the protein itself that accumulates in band rod-like structures. And what we see is that in the nuclei on the right side that's the nuclei, and within the nuclei, you have the accumulation of the protein. So when we discovered the gene in 98, it was published in 98, what we knew a lot about this gene and in fact this protein. PAPN1, which was called differently at the time, is a protein that does something very, very important. That's why it's been so difficult to find out what's going wrong. It's a gene that takes a lot of the messages, in fact, most of the messages that code for protein in our bodies, and adds a tail of polyadenine, which is different from the polyalanine of the protein. But anyhow, it does this tremendous work, and that helps to control what gene is going to be expressed. And it's very complicated biology. But what we found is, in fact, if you have a larger tail, the protein tends to accumulate in those foci or intranuclear inclusions. And what you see is that those inclusions are mixed. There's the abnormal proteins, there's good protein. There's also a lot of factors involved in protein conformation, protein destruction, and many transcription factors and splicing factors. So it's really, it seems to bring into these accumulation a lot of factors that you can imagine with time would cause problems with the cell. The cell has a drain within the nuclei of proteins that are very important for its work. So this is a neat image. It shows you just taking that alanine stretch, and if you have a normal alanine stretch, it gives you those very nice filaments. If you have this is a wild type. If you prolong the fragment, then it becomes more of a long stretch. So in fact, it's chemical. It's a chemical thing. The longer the protein, the more aggregation prone, the more it will create other physical realities. So what's going on? You have one copy that's fine and one copy that's bigger that's wrong. And so that copy, what is it doing? And so there's many ways of thinking about that in genetics and thinking of disease, genetic disease. So you may have this longer copy, may have a new function. It does something that's not supposed to do and creates all types of problems. So it's easy way to say, well, it's like creating a hook, and the longer it is, the hook is higher, and then it takes all the proteins and it will form aggregation, that what I drew in the previous image. Or it could also cause a loss of function in a way, and they're not incompatible in that sense, is that the long copy is often close to a normal copy. And because the long copy brings them all together in a lump, you're continually losing the good copy. So in fact, you're having less of the function. So it's a loss of the function of the protein. I must say, we discovered 20 years ago, we already do those functions, and we're still struggling despite the major changes in technologies. We still don't have a full answer as to what happens. It's complicated because this has an impact on hundreds, if not thousands of genes in the cell. In the context of this presentation, what is interesting for you is that there are people who really promote that, in fact, it's a kind of premature aging. That with aging, the protein normally works a bit different in cells, and with aging and in OPMD, where you're losing some of the protein, it becomes even more difficult. And some muscles that are known to age more quickly are just start aging faster and create dysfunction. So one example is exactly what Jean-Denis Brisson talked to you, is one of the weaknesses is the proximal weakness. And that's a muscle that is the muscle iliopsoas that lifts the thigh, is a muscle that we know ages a little bit quicker than others. So in fact, if you look at an elderly population past 70, many people will have weakness of that muscle. Not as much as in OPMD patients, but many people. Ptosis may also be related to the fact that those muscles age with time. We know they change with time. So the idea would be that the mutation creates a premature aging, in particular in muscles that have a tendency to age a little bit faster. So that's why there is a concern about doing too much exercise and burning your muscle. It's not because they will burst, but it's just you're losing some of the replenish capacity because they're already aging muscles that you're making them age a little bit faster. So I would certainly use caution. We don't have evidence, as Jean-Denis told you, either way. I think we need to encourage exercise, but we need to be cautious and listen. People have to listen to their body, but it is probably a form of premature aging. And why it affects not the brain, though there's some people who pretend that it may have an impact on the brain. I don't think the evidence is good. It seems to impact mostly muscle and certainly mostly some skeletal muscle. So still the answer is not out. So just a short review of treatment option, because that also has evolved. So the ptosis started by the most visual presentation. So we recommend that people be operated when certain symptoms appear, and that has to be adapted to the work and the circumstances, because if you're a salesperson and you look sleepy all the time, it's going to have an impact on your sales. So maybe you'll be operated earlier than someone who's at the computer. It doesn't make any difference. So you have to be nuanced in your recommendation. But if you have clear night vision difficulties, neck pain, if you have an important coverage of the pupil, you need to be operated. A lot of people did non-permanent surgery that need to be repeated 3, 6, 8 years later. Now we tend to do a permanent surgery. It's under local anesthesia. It has to be done by good surgeons, but there's many good trained people to do that, which will use the frontalis muscle to bring up the ptosis. It's called the frontal suspension. It works marvel. It's for life. And that's the way to go for most patients, except if there's an anatomical contraindication or other. So we now have a kind of permanent surgery for the major symptom in terms of the face. The treatment of dysphagia has also evolved, and the Saguenay played a big role in that, in the sense that the first study in '97, published by Jean Mathieu and Jean-Pierre Bouchard, but very promoted by Jean Mathieu, was to see if we could dilate the sphincter that seems to get constricted over years. And in fact, it aged more, it's more fibrotic, and by using a dilatation. And they showed very clearly at the time that yes, you could really have a symptomatic benefit. And that would last 3 months, maybe a little bit longer. It can be repeated. There's different technical tools to do that. But that seems to be the technique that worldwide becomes now the first technique. In Montreal, we used to have an extremely good surgeon, Dr. Duranceau, for the people who know him, who did a lot of surgery, and we had amazing results. People who swallow normally for 3 years after the operation. Unfortunately, we discovered over the years that it was really surgeon dependent. And we saw people, there's very good centers in Paris, for example, but other places in the world, the surgery was not done using the best technique, not by good people, but they just didn't use all the detailed technique and the extensiveness of the procedure. And a lot of people were worse afterwards. And that's why with no good surgeons, you don't do this. And that's what we recommend now in worldwide. If you don't, first of all, do the dilatation. If you don't have access to good surgeons, contact me and I'll find you a surgeon if possible. It's really surgeon dependent. So we have to watch out. All the more talked about and written about Botox treatment, no good rationale, no clear evidence that it's worked. So if people make that recommendation, I think you have to be cautious. And don't forget, Botox is never a permanent either solution. So probably not the best solution. And there's been some minor complications. But can we do something else medically, that is? I recommend mouthwash. A lot of people have their flora expands overnight in their throat because of the position and the fact that the entire throat opens up with the loss of muscle. So a good mouthwash can bring down the density of fungus in particular, and then you will have less of a syrupy saliva, and you'll have less problem swallowing during the night, so less of the phenomena of thick swallowing in the morning. In Saguenay, I've tried it, no success, but in Saguenay, they've been recommending amitriptyline as a side effect medication where you dry up the mouth. It can be tried. I have no success, but in Saguenay, they've had some success with that. Please, 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 people have to refrain from statins. At l'Institut de Cardiologie in Montreal, if you have Opmd, they will remove you from statin. It just makes the disease worse, even with no major symptoms. And if you have to use statin, which are anti-cholesterol medication, anti-fat medication, you should be monitored. And often the CK, which are enzymes that are liberated with muscle injury, go up and it stops. So there are alternatives, not only diet, but other medication. So please don't use statins. There's some pain management issues, but it's rare. But if people have Opmd and have pain, don't say it's unrelated, but it usually isn't. Most people don't have pain, but it should not be excluded. We have patients who do have pain, and there's probably a relationship. They tend to have a more severe muscle involvement also, so they may have a kind of double hit, Opmd plus something else that contributes to the pain and the severity. Head elevation at night, very important for breathing in general, less complication of having aspiration at night. So we prescribe electrical beds in Quebec, and it's often reimbursed by insurance to have a better drainage during the night. We use lift chairs, very good, because as Jean-Denis told you, it's this weakness going up from the chair and going upstairs. So a lift chair can really do that first step and bring you up. Most people continue to walk, even the wheelchair user at home. It's a very, very small percentage. It's not 14% who lose walking in the absolute sense. So I think we have to be nuanced in there. It's not as high as that as absolute walking. But there are some who are bedridden, but it's very rare. So I said electrical bed. Cane. Some people have a cane with an extra part to cut the stair height by half. That works pretty well for a while. We have adapted driving. Some people will drive only with their hands after a certain time. Again, rare. A lot of people use wheelchairs and scooters. If we talk of aging, premature aging is not going out to eat with folks. So we make recommendations about eat what you like, order what you like, or eat before you go out, but please go out. If you're going, please have ways to, driving a car is great, but if you want to walk on a boardwalk or going out for some kind of outing, please have a wheelchair, a scooter, something that you can just continue your life and share with your loved ones and friends. So it's really important to be proactive so that people just don't age at home and not enjoying all they could. So the future treatments, and that's a hard one in the sense that the only medication at this point, that's a long rational list, and I'll share the presentation and people can use it. At this point, there is, and I'll go only for the green, and again, I said I'm in some degree of conflict of interest, but they're not in the therapeutic space at this point. So there is a very high tech approach using genetic silencing, which has been shown in mice, and now there's probably going to be a human trial. We really need vector. There's even ways maybe to give it to the entire body and cure the problem. But can you imagine the complexity? 2 copies of the gene, one is abnormal, I'll show my abnormal finger, and one is normal. and they inactivate both, and you need those genes, and they put in a good copy, and that seems to be sufficient to ensure the cell to have a normal to work properly. So it's a major enterprise, but it works in human animals, and now they will try it. At this point, they're just trying to see if they will be able to repopulate the mouth with good muscle, so that people can swallow better and decrease their risk of pneumonia, aspiration pneumonia. The other is trehalose that was tried, as I said, but only with 12 patients, so it's a smaller, and we're still waiting if we're going to be able to do a trial on a larger set of patients. There was a myoblast transferred in France. A company wanted to make it an official treatment, but it's pretty out of the picture at this point. It's very difficult to grow myoblast in an industrial way with high quality. It's difficult. CRISPR and other means of techniques have been used in cells, not yet in full animals, so it's still in the vanguard, but it's being explored, and some of it has been done in the group of Giroulo and Aboubacar and at McGill. And we've tried every possible drug, FDA-approved drug, and at this point, there's still some interest in guanabens, which is not produced anymore. I don't know. A French group wants to see if that would work. There was some interest at one point with valproic acid. It's not. I don't think the trial will ever be launched. So drug-wise, except for trehalose, we have not yet found a way, a new drug on the horizon short term. So I think we still have to hold tight and hope that trehalose will be tried. We'll learn with better outcome measures how to do trial, and hopefully it will work. It's a demanding drug because it's an intravenous drug that you have to take every week, so it's not straightforward. But still, the preliminary studies showed very encouraging results, but we still need the placebo-controlled study to see that. So I think things are on the horizon, not in the next year, but there will be a trial probably with the virus in the throat, and then hopefully the trehalose, and then you never know in research, and that's why we love this work, and we never know, and we're all looking for other drugs, and there's other screens being done and things like that, and we may very well find other drugs. And you have to remember that because it's an aging disease, if you want, whatever we find on Opmd can be relevant for the others, aging disease, premature aging disease, but the inverse is true. So we may have a new category of drug coming out that for an anti-aggregation drug that suddenly works okay with the disease it was defined or found with, but works marvels with Opmd. So hopefully we'll be there. So on this, I'll stop, and thank you again for the invitation, and certainly I'm willing to answer your questions.
Thank you. We first have a comment while we're waiting. So we tend to use atropine eye drop to be found for focal treatment of hypersalivation with good effect instead of amitropine. So,
okay, atropine, yeah, that's another way of doing it. See, that's the kind of small trial that could be done, and that has been done in other rare disease. Think of Allertech and myotonic muscular dystrophy. It could be a way to just see if it's a good treatment. Empiric treatment is great, but it's often difficult. And I think the Signing group has studied so much dysphagia. We know that it's a fluctuating thing, and there's always a desire. So that would be a neat little trial to do.
Other questions?
Cynthia, I do see someone has raised their hand, so I'll go ahead and allow them to talk. They might want to speak their question. So one moment.
Yeah, sure.
Maybe we should ask all the other speakers to come on live in case the question's for them.
Louis, you can go ahead if you have a question.
Yeah. Okay, Dr. Bray, I have the sickness, and I read in a newspaper recently that Meditech Biopharma was supposed to put in place a clinical trial for human in next year probably, because they closed the trial with dogs, and supposedly that the results were good. So I know that there will be a reunion in France next month, and they are supposed to decide if they will try the BB301 on human next year.
So I think that's certainly what's said on the. Obviously, I cannot say more than that. That's what they've said, and my understanding is that they're really very keen on doing the trial. And I think the Saint-Guilly group, the group in Paris is now the best group to offer the access to the patients in this trial. They're the ones who had done the myoblast transfer in the throat, so they have a lot of expertise. So I think it makes sense. So yes, and certainly if you're trying to correct me in terms of chronology, yes, the Benetech trial is planned, not too far down the road, but it's a trial with very few patients. We're talking about a phase 2, I think, with very few patients, less than 10, I think. So it's still so I think at this point I don't know. I don't have privileged information more than what you've talked now. So yes, it's coming, but it's not the step where it's close to a larger trial for many people.
Okay, so what you're saying is that the first step in the trial will be limited to friends and a few people.
Again, I haven't seen, and I wouldn't be able to talk about it anyhow, the final details of the trial. My understanding was the next step was not testing 50 people. And where they come from, that will depend. France, I suspect they wanted to take people in France because of, but would they take patients from elsewhere? I honestly don't know the answer to that. The French clinic in Paris is the reference center for entire France, and they follow a few hundred patients, so they have patients.
So as a patient, I will have to write to them to know if they will accept foreign patients.
You can certainly write to them. They're very good company and nice people. Yes, you could write to them. I don't have that privileged information at this point.
So will it be possible to obtain the exact name and address?
If you have mine, write to me. I can try to find the way for you to communicate with them.
Okay, thank you.
Thankfully.
Thank you. I've got 2 other questions for you. Is there any benefit to getting genetic testing for someone that has a strong family presence of Opmd?
So that's a very good question, and one that I get in the clinic almost every week or by email. So at this point, the general framework is the one that of contemporary genetics is you don't establish if someone is a carrier of disease before they have symptoms if you don't have preventive measures or treatment to delay the onset or to treat simply. So at this point, when we see patients in their 40s and they come to see us in their 30s wanting to know, we tell them, why would I tell you when you're going to develop this disease? And usually they come at that age because their parent is ill, feeling more of the disease, and they're concerned whether they have it, and if they have it, whether they transmit it to children. All excellent questions. However, what we've learned from genetics, not only in Opmd and others, if we do a test for a pre-symptomatic person, we have to give them support, because what happens is we're announcing to someone, let's say who's 42, who's married, has 4 children, that he will develop the disease of the parent, but in 15 years, it will be bad in 25 years. And then the couple, the family, everyone has to adapt to this kind of new reality. And then they're saying, what are we going to do? We can't prevent it. We can't. You're going to stay active. Yeah, we're going to stay active anyhow. So there's no impact. Then depending where you are in the world, there's always the possibility of genetic discrimination. So I tend to have an open approach. I discuss it. I feel it's a very important questions. And then I always tell them the test is so simple, so cheap, so simple, there'll be a good time. And usually they go, the patients, the people at risk will go through a process, and they come back a few years later when they say, oh, you know, I can't eat chips anymore. It's just no. And then we do it, and they're positive, and then they say, oh well, okay. At least now I know I'm confirmed. I'm just going to enjoy life, continue. I know I'm going to develop it, and that's fine. So there's just a good time, and it's individualized. But we tend not to do pre-symptomatic testing. It's a tricky business and can lead to a lot of personal, familial distress and really no benefit.
I got another question. Is the ptosis surgery still only partly covered? My mother had to pay for cosmetic surgery to complete the process from the removal of excessive skin.
Yeah, that's a good question. Obviously, that, as you know, the health system in Canada is provincially, and so it's different from all places. So the idea depends who operates you. So in Quebec, a surgeon who will make you pay plastic surgery for eyelid ptosis correction in OPMD is, I won't say the word, but you understand. There's no cost. If you see some people who say, I have to remove a fold of skin because like me, they have a little bit of a heavy upper lid, and that's cosmetic surgery, but I have to operate you because the ptosis in OPMD, most surgeons will not pay, will not bill you for that. But some do, and I won't say the word, but you understand. So you have to go to see surgeons who do it a lot, who know that there's no reason to, the cost is minimum here. I mean, it's not much. So it doesn't mean they won't do it well. And I think the major issue in OPMD and surgery for the eyelid is access. The access to the good surgeon is through the public system. The access to the other surgeons, which are technically very good, is through a private system. So when they come in, they're there to do a good job, but also make money. So they will do all those extras. But in Quebec, ptosis correction with some degree of removal of the skin fold is usually no cost to the patient.
Okay. I got a comment. Oh, I got a comment from ptosis surgery for OPMD is covered by OHIP in Ontario.
Absolutely.
Dr. Warman. And now, how many times can a patient undergo a cricopharyngeal dilatation?
I'll ask Jean-Denis. I don't know what's the statistics. I mean, I don't know. I don't have the experience they have in Saguenay. They've been doing it for over 20 years now. So what's the maximum, Jean-Denis?
I know in our retrospective study, we have that data. Some people had almost 10, I think, over 6 or 7, I'm sure. I don't remember what was the highest number. I would have to check.
It certainly can be repeated, and that's for sure.
Yes, a couple of times.
Okay, is there any other questions? I don't think I missed anything. Is there any other question from other speaker? Well, then I think that, I would like to thank all the attendees. And I think that, Amira, you had the first, yeah.
Yeah, no, this is great. Thank you again to all the speakers, to NMD4C and MDC. We're really pleased to have this opportunity to share this information. It's been really helpful. We're also really grateful that for today's webinar, even though it's ECME, it's accredited, we were able to have individuals who are affected by OPMD join us as well. I put in the chat box what our next session will be on in May. It's a neuromuscular mystery case rounds. We welcome you to go ahead and join that session. A recording of today's webinar will be available as well, and there is a survey that we'll follow up on following today's session. Thank you all so much. Thanks for joining this evening, and thank you again, Dr. Gagnon, for moderating and presenting.
Thank you for the invitation and the ability to present our work.